we go to the keynote speaker. There is no need for introduction of Dr. Sumitha Agarkar from Shankar Netralaya. She is the HOD of Pediatric Ophthalmology Department there and the Joint Secretary of Strabismology and Pediatric Ophthalmology Society of India. Over to Dr. Sumitha Agarkar for a difficult topic, management of strabismus in thyroid eye disease and imaging too.
Yes, talking about thyroid is easy. Managing it is difficult. So I'm here, I'm only talking, so I think it's not that difficult. So thyroid eye disease or thyroid orbitopathy is acute, basically a clinical spectrum of clinical disease which has involvement of muscles, optic nerve, orbital tissues, as well as even the ocular surface and cornea in the later stages. But if you look at the muscles or strabismus point of view, we have two clear phases in the whole disease spectrum. You have acute inflammatory phase with a lymphocytic infiltration and congestion of the orbital tissues, which can lead to pain and sometimes diplopia and ocular movement limitation, for which the patient come to us for that. And then there is a chronic phase where there is a adipose tissue infiltration and fibrotic changes in the extraocular muscles, leading to tight and fibrotic muscles, leading to a restrictive strabismus. So it is almost, strabismus is seen in 17 to 51% of the patient depending on the racial population. Fortunately for us in India, we don't see it that often with thyroid eye disease the way it is reported in the Western literature. The risk factors which are associated for strabismus are age. Middle-aged patients are more likely to have than younger patients. Women have more represented in children in strabismus with thyroid eye disease. Smokers, definitely, because smokers with thyroid eye disease are twice likely to need strabismus surgery compared to non-smokers. And definitely family history of thyroid eye disease, sometimes that also plays a role as a risk factor. So this is how a typical patient might look. Here it is difficult to assume which eye is actually fixing because both the eyes have severe disease. But you can see there is proptosis, there is limited ocular movements, though I can't make out from this picture, but there is proptosis, there is lid retraction, there is strabismus. You can see almost the entire spectrum of thyroid eye disease in this patient. So basically it's a autoimmune disease, as we all know, and leads to lymphocytic infiltration, edema, and then leading to increased orbital volume, proptosis, and increased intraorbital pressure, and ultimately at some stage leading to fibrosis and restrictive strabismus. It is also influenced by genetic and environmental factors, genetic factors like family history and environmental factors like smoking. So this is a patient, as you can see, there is right esotropia in the primary gaze, but there is restriction of abduction in both the eyes. So it's slightly asymmetric involvement, but medial rectus both sides is likely to get involved. He also has, you can see elevation limitation in both the eyes. So if you look at the muscles, this is the frequency of muscle involvement. Inferior rectus followed by medial rectus is the most common presentation. But do not forget that occasionally even obliques can be involved and you have to look for it. Why inferior rectus? Because probably it is the bulkiest muscle which is and it is tonically very active muscle. So that muscle is probably most likely to get affected in thyroid eye disease. So what are the investigations? You would look at thyroid function tests. You will, from strabismus point of view, diplopia and Hess chart. This helps in monitoring the disease. And post-duction test, which is the most important test, which you have to do it before you do anything surgically in these patients. And of course, imaging. The STIR or short tau inversion recovery way of imaging is very, very helpful in outlining the disease activity, because this focuses on the water content of the muscle and suppresses the fat. So you can see activity of the disease very nicely in this kind of imaging, and also delineates the muscle involvement and optic nerve compression. CT orbits and ultrasound can have a limited role. So in the imaging you can definitely see fusiform enlargement of the muscle bellies here, and you can also see there is strabismus. So these are the differentials, and each of them can, sometimes myasthenia gravis can coexist with thyroid disease, and you must keep the possibility in mind. Inflammatory conditions like myositis and orbital inflammation can mimic thyroid disease, and sometimes even the space occupying lesions of the orbit which can affect multiple cranial nerves can also look like thyroid disease. So management of strabismus is basically divided into medical management and surgical. Medical management involves keeping the thyroid eye status of the thyroid in control, radiation therapy if required, botulinum toxin for small angle strabismus, and prisms will go through it one by one. So prisms can be used as Fresnel or ground-in prisms depending on the angle, and it is definitely, you can give it as a definitive treatment for small angle deviation, but if the angles are large it can be only a temporary treatment while waiting for strabismus to stabilize. Botulinum toxin, there are very few reports, but poor surgical candidates which cannot be treated with prisms, botulinum toxin has been tried, and Dr. David Granett has written a lot of his experiences have been published. Only problem here is downside is recurrent injections and difficulty in precisely delivering, because orbits are tight, bulky, and sometimes it is difficult to really deliver the injection where it is supposed to go in the muscle belly. Now surgical indications will be intractable diplopia on primary gaze or in down gaze, abnormal head position, and if it is cosmetically very disfiguring strabismus, then definitely you need to do something. What are the challenges? Outcomes are likely to be suboptimal. Muscles can be very tight and fibrotic. There is incompetence. Sometimes the angles are different within the gaze itself. Like you will have angles, hypotropia of 30 here and 25 here and 20 here, and then it's very difficult to plan surgery for these. So your surgical dose calculation becomes complicated in view of severe incompetence. So here you have to spell out your surgical goals very precisely. It is impossible to make them single and make them aligned in every gaze and everything. So you have to clearly tell it to the patient that you are going to achieve just enlargement of the binocular single vision field, and we are going to probably look at practical gazes, which are the primary position and the down gaze. So surgical dose calculation is because nomograms do not apply in these conditions. So the dictum is a lot gets you little and little gets you a lot. So smaller angle needs larger recessions and larger angle needs smaller recessions. Timing of the surgery you have to do in active stage when the disease activity is least, which can be determined by your orbital colleague or on imaging. If orbital decompression has been planned, then strabismus surgery is best done after that, because it can alter the strabismus, at the same time can produce new strabismus also. So orbital decompression, if at all everything has to be planned, it has to be only after decompression. Stable measurements for at least 6 months, and as I said, your MRI can also help you to decide when is the quiet and the disease is quiet. So most common surgery which we do is recession of the tight muscle. Resections are better avoided, but there is, I just found this article published in 2017 where as a second procedure, if you have got residual, you can plan for small resections, and they have reported good results, although the N is just 10, but probably as a second procedure or for a small angle remaining residual symptomatic patients, you can look at resections also. So adjustable sutures, there are two schools of thought here. Some people advocate adjustables, some people say that adjustables lead to late overcorrections, and which is probably true in the cases of inferior rectus recessions, where adjustable sutures using adjustable suture probably leads to late overcorrections. Non-absorbable sutures are preferable compared to the absorbable one. So this is what you need to counsel the patients, that you may need multiple surgeries, you may have subnormal or suboptimal outcome, and there may be surgery can actually increase the proptosis as well as late retraction. So when you plan for surgery, preoperative consideration should include primary, secondary and tertiary actions also. You should know how to get rid of torsional action by moving the vertical muscles or moving the horizontal muscles, and you should keep that in mind when you're, because the less you do is always going to be the best. So fusional range consideration, so always leave the previously hypotropic eye with a small hypo, don't make it hyper, because that patient can become very, very uncomfortable. Keep the ocular torsion as a factor when you're planning surgery, and a lot more times FDT is far more informative than imaging in these conditions, especially when surgery is being planned. Intraoperatively, just perform ductions. Forced duction test is essential before and after the surgery, and also after the conjunctival closure. In large muscle recessions, you also should plan a small conjunctival recession, because sometimes conjunctiva can produce a tether of its own. Dissection has to be very neat, and particularly around inferior rectus, so that lid retraction worsening can be avoided. So as I said, adjustable is a little bit of a controversy. There are enough people who are on two groups. I personally don't do adjustables in thyroid eye disease. I use fixed suture, and so as I said, key concerns with adjustable suture would be muscle slippage, scar elongation and progressive overcorrection, which is fairly commonly seen with inferior rectus. So intraoperative, you have to be prepared for a very tightened muscle, which can lead to pull-in 2 and a friable and shortened conjunctiva. So you need to have some special equipment like a double Kowal hook, or a forceps which has these kind of blunt edges to hold the conjunctiva, because conjunctiva is very friable. There is another technique which you use is intraoperative relaxed muscle technique, where to decide how much recession you should do, because in these cases your normal surgical nomograms don't apply. So basically you disinsert the muscle and let it slip back, and wherever it rests you suture the muscle there while you hold the globe in the primary position. And Del Canto et al. Have reported good results with this technique, and this usually is self-adjusting, and you can probably get good outcomes out of this. So as you can see, sometimes less is more. This patient has a very significant hypotropia, but just with one muscle recession, just an inferior rectus recession, you have got a fairly good result in this patient. So these are the complications, and late overcorrections are known. These are the methods by which you can prevent the late overcorrections of inferior rectus recession, because late overcorrection can give rise to diplopia in the down gaze, which is patient will complain. So this is a serious problem when you are trying to do the surgery. Again, A pattern exotropia is fairly common, and that can be little bit obviated if you are doing to do with bilateral inferior rectus recession. You can just shift the patient medial rectus inferior rectus can be medially transposed by half tendon width to reduce the exotropia, but this transposing the inferior rectus medially also gives rise to torsion, so you have to be a little bit careful about this nasal transposition of the inferior rectus. So summarize, surgery only if it is cosmetically quiescent stage, do a conservative therapy, give attempt for all, and do talk about lifestyle changes to the patient. And standard surgical nomograms are not applicable, so you may have to plan as you go along during the surgery. Thank you.
Thank you, Dr. Sumitha, for making an elaborate, giving a talk on a tough subject, thyroid eye disease. And strabismus in thyroid is always difficult to manage.